So we're going to talk about the challenges and strategies for the implementation of artificial intelligence in healthcare. And those challenges are significant. So the first title of my talk is Bridging the Gap. There is quite a gap. So we're going to talk about that. So as Abdul was saying, I work at University of Cambridge in the Department of Public Health and Primary Care at the Healthcare Improvement Studies Institute. So just a little bit about my journey so far. I'm Dutch originally, as you might be able to hear. I studied computer science and artificial intelligence in Utrecht, and then worked at the University of Amsterdam at the Department of Medical Informatics. 10 years ago, I went to Manchester and worked there at the Center for Health Informatics. And since recently, earlier this year, I work in Cambridge. So my background is computer science and AI, but the broad field that I work in, I would say, is data science and health informatics. And specifically things like clinical prediction models, electronic health records, healthcare quality and safety, and clinical decision support. When I'm not doing all these things, I like to go for a nice hike. So you see my hiking boots there, play the piano, or have some nice food. So what is it that we do at the Healthcare Improvement Studies Institute, abbreviated this institute? So healthcare improvement is a field that focuses on enhancing the quality, safety, and outcomes of patient care through systematic changes and innovations. And we believe that that should always be based on evidence. And also, whenever we do it, we should use the opportunity to generate new evidence, to understand what works, what doesn't work, and why it works or it doesn't work. So our mission is to enable better healthcare through better improvement evidence. And we create an actionable evidence base for improving healthcare, working collaboratively with patients, staff, and other stakeholders in the healthcare service. So that's what we do. In this lecture, I'm going to talk you through three topics. So first, I'm going to talk about this gap problem that I was alluding to earlier. So the last mile problem, as Enrico Chiera has called it. Then we're going to talk about the healthcare AI algorithm journey, at least as I think it should ideally look. And finally, we're going to talk about healthcare AI implementation and specifically what we know about that topic. And we conducted a small literature review earlier this year. So I'm going to present the results of that review. It's not been published yet, but I think that's pretty imminent. I'm going to end with a couple of take-home messages. So let's start with that last mile problem. So here's a report that appeared towards the end of the COVID-19 pandemic in the MIT Technology Review. And it said hundreds of AI tools have been built to catch COVID, and none of them helped. And the reason that none of them helped was that none of these tools had been actually deployed in clinical practice, in frontline practice. And this was based on a review that was published in the British Medical Journal around the same time, where, there were hundreds, indeed, of prediction models and similar types of AI tools identified for COVID-19. And indeed, very few, whether it was none, I think that's a little bit stark, but I think very few of those ever made it to frontline clinical practice. So that was quite disappointing if you consider that, in order to make this happen, governments typically change the legislation for healthcare data access. In many countries, at least, that happened. So it was easier during the pandemic to access routinely collected healthcare data. And they also invested massively in COVID-19 research broadly, but specifically also in AI research for COVID-19. So yeah, there was a lot of effort and investment that went into this, and it didn't really help any patients, you could say, very few at the very least. So this was for COVID-19, but actually it wasn't so unique. So back in 2016, so before the pandemic, there was a review of prognostic models in obstetrics. And this was done by a Dutch group, Klein Rauweler and colleagues. So they identified 177 papers that reported on the development of 263 prognostic models. So these were models that typically predicted outcomes like preeclampsia, preterm delivery, the mode of delivery, gestational hypertension, etc. One of the interesting outcomes I thought of this review is that the performance of newer models, which were typically based on machine learning or more novel analytical techniques, was generally not better than that of older models predicting the same outcome. And those older models were typically based on regression. So they found that very few of these models were externally validated, whereas external validation is broadly considered a necessary step if you want to prove that your model actually works, so it can be taken to clinical practice. And then there were no studies that evaluated the impact of these models on clinical practice, and therefore none of these models is currently, or at least at the time in 2016, recommended by clinical guidelines, because before we would recommend the use of these models, we need to know whether they would actually have a positive impact on clinical decision-making and potentially on patient outcomes. But that was never studied for these 263 models. So actually a very similar situation as we saw for COVID-19. Here's another one, and this one is in psychiatry, and it was published in 2021, so a little bit later, during the pandemic. And this review identified 88 prediction models in psychiatry that included some form of validation, so they dropped all the models that were not validated at all. The most frequently investigated condition was psychosis, and that was followed by mood and affective disorders and anxiety disorders. What they found is that from these models, which all had undergone some form of validation, 27, so 30% roughly, had been externally validated. And only one model had been implemented in clinical practice, or at least at the time of writing this review, serious attempts are being made to implement it, and I think that actually happened. So again, very, very disappointing results. There exists a dashboard, which is called the Global Clinical Artificial Intelligence Dashboard. You might want to look it up. If you just Google that, then you would definitely find it. And it shows us the real-time state of AI research for human health. So this automatically analyzes the published literature, so it's always up to date. Obviously, that's not free of error, but by and large, I think it gives an impression of where things are at. So what we see here in the graph is in blue, all included studies, so all AI studies for human health. And then in, red or orange, it's mature studies, so studies where things have actually been tested in clinical practice. And you can see immediately that the total number of studies has been growing very, very fast since 2020, definitely, but also before that. So a very steep curve. Whereas that number of mature studies, it's always also growing, but the pace of the growth is much, much lower. And the gap between number of published studies, and most of those who typically present a new model, the gap between that number of studies and the ones that actually test something in clinical practice is widening, as you can see. So this is quite a persistent, I would say, and concerning problem. And I think increasingly also it's something that has been picked up by different people. So nowadays you read quite a lot about this problem. If we think about these figures, let's consider for a second what could have happened here. And I think, very broadly speaking, there's three explanations, and this is only scratching the surface. So the first is that very few attempts are made to implement these AI models in clinical practice. So that would explain, obviously, the gap. A second explanation is that those attempts are being made, but they are very often not successful and therefore not reported. So that's what we see in these reviews and in that graph. The third possible explanation is that attempts are made to implement these models, and they are successful, but they are not reported. It's not something that people consider worthy reporting. I think that last one is probably less probable than the first two. But in fairness, probably it's a mixture of all these things. So that does mean that we don't really know what's going on, and there's probably quite a bit here that's hidden under the surface. But still, I think it's reasonable to say that we've got a problem here with translation of research findings into clinical practice. And this is what I referred to this earlier. A colleague of ours in informatics, Enrico Chiera from Macquarie University in Sydney, refers to it as the last mile problem. So that's where artificial intelligence meets reality. And that last mile, as the saying says, is the hardest. All the steps that come before that, you could argue, are, relatively straightforward, or at least we know exactly what to do. But that last mile is much harder because we don't know exactly what to do. And that's probably one of the reasons why it goes wrong. The problem is also not entirely unique to artificial intelligence. I think it's important to realize that. So problems with translation, I think, exist across the entire biomedical field, and not just in the biomedical and health domain, but also in other domains. But if we look at the biomedical and health domain, then people have been looking at this problem for a long time. So here's, for instance, a framework that was developed, published 10 years ago by Gannon, which basically says, if we want to get things into clinical practice, so from bench to bedside, then we have to go through a number of phases. So we start off with a discovery phase that is very often, consists of research that doesn't have a projected practical application, perhaps not even a very specific disease focus. And then we move on to a development phase where the results of that discovery phase are translated into something that you could envision being used in clinical practice, so a proof of concept. And that proof of concept is then optimized for the intended real-world use. After that, we get what is typically called the translational phase. So the first in human studies, and if that is successful, a larger, more rigorous test, so typically a randomized clinical trial. And if that is successful, it would be followed by an implementation phase where we deploy the intervention or innovation in clinical practice and try to scale it up, because initially that would start typically on a relatively small scale, but obviously we want to, if it is very effective, we want to scale and spread that intervention. I think frameworks like that one have definitely some value, and to a certain extent also apply to our field, to artificial intelligence, but not perfectly so, I would say. I think I see, let me just go back to the slide because I'm still talking about it. I think what we see here basically is an overview of different fields rather than the journey that we would typically go through for an AI solution. So let me try to explain what we mean by that, what I mean by that. And I'm going to do that using a paper that appeared earlier this year from researchers at Duke University in MPJ Digital Medicine. And what they did is they brought a particular AI solution that they developed called Sepsis Watch. They brought it to frontline clinical practice. They implemented it at the Duke University Health System. And now the paper documents the process of doing that. So the process of designing, building, and maintaining the AI solution. And that took quite a long time. So it took 3 years overall. And what they did is basically interview the people that were involved, so the engineers and the scientists, and also other stakeholders involved in that journey. And they report the findings through a series of swim lane diagrams. I'm going to show you a couple of the next slides. that summarizes algorithm journey across 4 stages. So the problem identification, the development, the integration of the AI solution into existing systems, and finally, the life cycle management. And what they also do is provide this table. This is table 1 from the paper, which is a description of each stakeholder listed in the swim lane diagrams. I think this table is really important because it just illustrates how terribly complex this is, because you have to deal with so many different people if you want to make this happen. So we see here people like clinical champions, project managers, statisticians, data engineers, user interface designers, clinical experts, people involved in the health system leadership, university leadership, hospital leadership, cardiology leadership, because this was about cardiology, etc., etc. And in order to make this happen, you have to have every single one of those people on board with what you're trying to achieve. And that's a massive challenge. So I think this table says a lot. And it also feeds into the swim lane diagrams. So let me just move on. So here's one of those swim lane diagrams. I'm not sure whether you're familiar with them, but basically we see here a number of these stakeholders, not all of them. So in this case, we see 6 of them. And then different activities that have to be carried out by those different stakeholders, and how they link together in terms of time and decision making. And this is step 2 of the entire process. So this is development. In the middle here, it's probably too small for you to read, sorry for that. But in the middle here, the 2 green blocks here are build and validate the model and design the workflow and the prototype user interface. And there are then more detailed diagrams for those 2 steps. But I think this also nicely illustrates that what we often consider to be the most important, if not almost the only things that you have to do, I think this paper nicely illustrates it's only, these are only steps into something that is much more complex and involves a lot more than just these 2 steps. So I think it's a very good illustration of the complexity of all of this. So here's the diagram that follows. It's step 3A, integration and technical, and specifically the technical integration. And this one, as some of you may know, is specifically challenging, because you have to have the health system IT support on board with what you're doing and actively supporting your implementation effort. And that can be a terrible challenge. So to summarize this paper, I think there's a couple of lessons learned. So I think one is that the translational journey for healthcare AI algorithms basically follows the stages of the software development life cycle. So that's where we can get a lot of inspiration from. It's not surprising if you think about it, because it is a piece of software that we're developing. So it makes sense that that's where we should look at. And then the algorithm development and validation are relatively small and relatively straightforward steps in this very complex journey. The complexity really emerges from the large number of stakeholders that have to be on board, actively involved in the process. Finally, I think what's really important, and this is not something, it's mentioned in the paper, but this is also very much based on my own experience. This journey is very often unexplored terrain for everyone. So to all those people to whom you would speak in order to get them on board, they would never have done it before. And so they would also say, I'm not entirely sure how to do this. It's the first time that we do this, and what's the process? What's the, is there any guidance for this? And there really isn't. So that's definitely also something that makes it really hard. So I think if we look at the way that software is typically developed and the stages that we typically go through, and look at the findings of that paper, I would say the algorithm journey would typically consist of about 7 steps. So I've got them here on the slide. So the first stage, one that is very often overlooked, unfortunately, is what I would call the ideation phase. So this is where we make an effort to understand the problem and formulate an initial solution together with relevant stakeholders, so typically clinicians, but perhaps also patients and other stakeholders that are involved, perhaps the people who are going to have to pay for, what we're developing, etc. And do some data discovery to, understand if this is even feasible, what we're thinking, what we're developing, designing here. So that would be followed by a proof of concept. So that's basically developing your AI model and doing some internal validation. Then a more rigorous validation, so an external validation, followed by the development of a product, so something that people can actually use, a minimum viable product, a pilot deployment of that product, an assessment of the impact that it has on clinical decision-making, patient outcomes, and also resources and costs. And if that is successful, we could deploy at scale. So you recognize that there are some steps here that we have seen before. The flow of models would typically go from top to bottom here. And I think in terms of where most of the failures happen is in the actual deployment phases. So the pilot deployment and the deployment at scale. And there's two steps that I've picked out here because I think they're very often reported as really challenging hurdles. So the first is a regulatory assessment and getting regulatory approval. So that would very often involve a medical device regulation approval in the pilot deployment, and assuring business continuity if you deploy at scale. And this is also a step, I think, where typically academic groups struggle because they haven't got the experience of doing these things and they haven't got the people that are good at it. So we said that models would typically flow from top to bottom, but if we think about the flow of knowledge, so whenever we learn things, then that flow should be in the opposite direction. So if we find, for instance, that certain things do not scale well, so in the final step, then we should take that into account. And in future projects, we should try to take that learning and use it in the earlier stages, but probably already in the ideation phase, to prevent that we would end up with a solution that is similar to all the previous ones that didn't scale. So the flow of knowledge goes in the opposite direction, so from bottom to top in the diagram. If we look at these 7 steps, I think it's fair to say that there are 4 of them, which are relatively well understood and relatively well reported on in the academic literature, and for which there also exists reporting standards. So there exists something called the tripod plus AI statement. That's a statement that tells you how to report on the development and the validation of prediction models. And it's very widely used and widely cited. This specific statement appeared earlier this year, but there is an older statement that is called tripod from, I think, 2015 or 2016. And that's widely used in the field. We have a similar kind of statement for pilot deployments called Decide AI. It was published in 2022. And we also have one for the reporting of clinical trials, which is called the Consort AI extension. Now, I do think that, if you look at the published literature, then most studies would be in that proof of concept stage, so the development of the model, and much fewer would report on model validation, pilot deployment, and impact assessment. In fact, I think, for instance, the pilot deployment phase, I think it's really good that we have that Decide AI guideline, but it's not something that people frequently report on. You would not find many studies that tell you what they did in that pilot deployment. It's not considered an academic activity, and I think that's a real shame. I think we should try to change that. So in terms of the 7 steps that we saw, I think 4 of them typically are under-researched and underreported. So that's the ideation phase, the minimum viable product phase, the pilot deployment phase, and also that deployment at scale phase. And these are phases where I think people tend to believe it's just something that we should do, and it's not worth in trying to make a study out of it and report on it. And I think that's wrong. I think these phases need evidence and need an evidence-based approach as much as the other stages. We have it for the other stages. Let's try to get it for these 4 stages as well. So I think that's where a major gap is at the moment. There was a paper which also appeared earlier this year from a colleague of mine here in Cambridge, Florian Markowitz. And the title, so Florian is a very funny guy, so he's fantastic also to listen to. And the title of his paper was "All Models Are Wrong and Yours Are Useless." And this statement, "yours are useless," refers to the fact that the far majority of models is not being used. And if they're not being used, then they are useless. And he comes up with a checklist, if you will, to try to change this. So let me just bring that up to the screen. So checklist for useful clinical prediction models. And one of the things that Florian really emphasizes here, and I think he's absolutely right, is your model really addressing a clear clinical decision point? So that's the first one, as you can see. But then number 3 is, again, do you address a clear clinical decision point? Are you sure? Better go and talk to a clinical collaborator who's domain expert. And then number 5 makes the point again and says, do you address a clear clinical decision point? Are you really, really sure? And I think this is absolutely true in the sense that a lot of people overlook how challenging it is to identify that clear clinical decision dilemma. And it's tempting to basically take it for granted and just develop your model. And you will get it published. That's one of the issues. Journals don't tend to check this. So if you don't check it yourself, you will develop a model, publish it. It will be a nice publication. People will cite it, but it's never going to be very useful. So the other thing I think what's important related to what Florian was saying in his paper is that we should always follow the lessons of agile the software development, which means we should be prepared to go back. So we don't just follow these steps in the order in which they are given, but at each stage, we are prepared to go back and say, okay, we've done our proof of concept, but now that we have it, we realize that we overlooked some things in the ideation phase. So let's go back and redo it. And obviously we wouldn't start from scratch. And once we progress again to the proof of concept stage, we again can build on what we've done before. But we use the results of each stage to go back and think, are we still on track? Are we really doing what we believed we were doing in the ideation phase and all the other phases that followed? So I think that agile cyclical approach is extremely important. So I'm going to finish the lecture with an overview of a survey, a literature survey that we conducted earlier this year, focusing on healthcare AI implementation. We basically asked the question, so what is it that we know about this topic? What have people reported about healthcare AI implementation? We only looked at papers published in 2022 and 2023, so it was a relatively limited survey. And we focused on healthcare AI, clinical decision support, and implementation research. And what we found was a total of 31 papers. And so each of these papers explicitly talked about implementation of healthcare AI for clinical decision support. And we categorized them into 4 groups. So the first group was papers about implementation theories and frameworks. The second group was about assessing stakeholder perspectives. The third group was about implementation feasibility, so testing whether you can actually implement something. And the final group was about technical infrastructure to enable implementation of healthcare AI for clinical decision support. So let me talk you through those 4 groups and what we found specifically. So the first was around implementation theories and frameworks. And I think here it's important to realize that there exists a wide variety of published implementation theories and frameworks, and quite a few of those are very, very mature. And they were not specifically developed for healthcare AI, but they would still very often be applicable. What we found in our survey is that these theories and frameworks are very rarely used in the healthcare AI implementation research. And when people used existing theory frameworks, they very often used ones that were terribly outdated. So we came across multiple papers that used the technology acceptance model, TAM, that was published in 1989 and has been superseded by various newer models. The latest one is called Unified Theory of Acceptance and Use of Technology, version 2, UTOUT 2, that was published in 2012. So overall, a bit disappointing and even alarming that these theories and frameworks, they're either not just being used or the wrong ones are being used in healthcare AI implementation. Then the second group was about stakeholder perspectives. Now, this was a very large group, so 2020 studies. And typically these studies consisted of surveys or interviews or focus groups with stakeholders on healthcare AI. And typically these studies were conducted prior to development of a concrete solution. So really what they were trying to do is assess the general acceptability of any healthcare AI solution to the group that was being surveyed. And typical barriers that were cited in these studies were, for instance, doctors saying, well, if an AI solution would disrupt clinical workflows, that would probably not be acceptable. Or, for instance, if the AI would increase our workload because we had to, enter more data, for instance. People also said, that they were not familiar with the technology and wouldn't necessarily trust it. And some people said there's not an evidence base yet for healthcare AI, so it's early days. One of the things that struck us is that the majority of these 22 studies focused on healthcare professionals and typically doctors. And other stakeholder groups were very poorly represented. So for instance, CIOs or commissioners, regulators. So all those who do not have a frontline clinical function necessarily, but have an important role in healthcare innovation, they were poorly represented in these studies. So the third group consisted of papers looking at implementation feasibility. So these were pilot studies that evaluated the feasibility of healthcare AI implementation with concrete systems. It was not a very large group. I think we found 3 papers. In the studies that we found, there was very often a poor interoperability between the AI and existing systems. So what happened, for instance, is that people would deploy a new AI model, but that AI model wasn't integrated with existing systems, which meant that then the users had to enter data twice. And not surprisingly, that specific pilot was a failure because that's not something that makes people very happy. There were also, I think, 2 studies where the clinicians were not satisfied with the accuracy of the AI algorithms. And one explanation for that is that the data quality of the systems that were used to produce the outputs was very poor. So what happened there is that the AI algorithm had been developed originally on high quality data, for instance, from a trial or a cohort study. But now it was deployed in the real world, and it had to use routinely collected data, for instance, from electronic health records, of which the data quality typically is much, much worse. And the result is then that the outputs aren't very good either. And clinicians detected that. So they saw that a number of the outputs were really not correct, not accurate, and started to abandon use of the AI system. So then the final group, which was, I think, very small, 2 papers, looked at technical infrastructure required for healthcare AI implementation. I thought it was quite an interesting group, actually, and something which I feel is also underreported. What these studies found is that healthcare organizations very often lack the technical infrastructure and processes for integrating AI solutions. So what that means is then if you try to do that, you have to go through very long processes to make it happen. Sometimes technical development is necessary, but also you have to go through very long processes to get approvals. For instance, to exchange particular data items that you need for your AI algorithm. And there were often also further delays caused by cybersecurity concerns that the AI system might cause some security leak. Now, obviously, those concerns are understandable, and it's the job of the IT people to look after that and make sure that everything is secure and that any exchange of information, for instance, is backed up by proper governance. But I think healthcare organizations very often can improve a lot by creating the infrastructure and processes to do this relatively quickly and on a more or less routine basis, where you try to integrate new AI solutions routinely, perhaps every couple of months or so. And at the moment, that's clearly not the case. Right. So let me finish with a couple of take-home messages from this story. I think to summarize, I think it's fair to say that today most healthcare AI investment has focused on developing algorithms and improving algorithm performance and developing proof of concepts or models, but not to delivering real-world impact. And the reason for that is that making that real-world impact happening is so complex. That journey that we discussed is very complex, and the most challenging stages occur early, so understanding the problem, and late, where we deploy the AI solution into existing systems and processes. And as we saw from the paper from Duke University, especially these later stages involve so many different stakeholders that you have to get on board with what you're trying to do. I think it's also fair to say that healthcare AI innovation research is still in its very early days, and it needs to grow and mature as a field in its own right, and better develop its evidence base, because for quite a few steps on that journey, at the moment, we don't have an evidence base. People are just doing something, but they can't rely on published evidence in what they do, and that's not good. A lot of people have asked me, oh my God, this is such an enormous problem. And you were talking about how fields should change. But what is it that I can do? If I am working on this, how can I help? And I would say to that, try to study the stages of the healthcare AI journey that are under-researched and under-reported. So that ideation phase, the phase where we create the minimum viable product, the pilot deployment, the deployment at scale. Those are the phases that currently are not very often reported on. And I think that should change. I would also say, make sure to ground your work in theory, because that's the way to build up an evidence base. And it does mean that sometimes that theory will have to come from fields that are unfamiliar to you. So then you might have to work with people from other disciplines. I personally think that's quite exciting. But I think it is important to do that. And we can't just rely on everything that comes from our own field if we're serious about making this happen. And finally, make sure to report on what you do and on the things that you find, even if you fail. So we can't expect every implementation project to be a success, far from it. But we can only learn, we can probably learn more from the failures than the successes. So that is really important, I think. So I've listed here the literature that I cited throughout the talk. I'm happy to share my slides. I will send them to Abdul so he can share them with you. And I would like to thank you for listening.
Thank you very much, Neil. Thank you.